right, welcome to episode 3 of Reimagine Wellness. I'm Ryan Dominguez, along with my host, Mike Rossi. We're so excited to have our third original guest on today. He's a doctor of emergency medicine, focuses on very acute care, and is also a well plugged in person in the metabolic health community. So I'm very excited to welcome Dr. Kolodzik, and thank you for coming on.
Yeah, thanks, Ryan and Mike, for having me. Excited about doing this.
Of course, awesome. So I think not all of our viewers will be familiar with you. Definitely some of them will be. So I think it would make sense to ask first off just a little bit about yourself. As I noted in my introduction, you're in emergency medicine and would love to know, like, how did you get into emergency medicine? What are you passionate about the subject area? And would love to just hear your thoughts on that.
Yeah, so initially out of medical school, I had an interest in emergency medicine, an exciting field growing at that time. That was back in the days, even before, ER was on TV. But just, very stimulated by the excitement in the emergency department and decided to head that direction. I was actually one of the earlier residents in the field when emergency medicine was just getting started. Initially, there were no trained emergency physicians. It was usually family practice docs or surgeons who decided that they wanted to go that route. Or even in some of the early emergency departments I staffed, it would be like the family practice guys would work the days, and then we would come in and work the night shifts. Or you'd have a surgeon that would pick up a shift here and there. So that's changed over the last 30 years. So that now most emergency departments are staffed by board certified emergency physicians who have made that career. So it was an exciting time in that specialty. A lot of growth. I helped start an emergency medicine group that grew from a couple contracts to 60 contracts. Just the business aspect of that is the way that works is physician groups contract with the hospital to provide the physician staffing. So that was a lot of fun and very exciting. And then after, having some administrative role in that group and being an emergency department medical director for a number of years, I decided I just wanted to pull back. And the term we use is just pick up charts. Just pick up the chart. This was before there were computers, mind me, in the emergency department. So just pick up charts and go see a patient. And I still am excited by that. Just walking in the room, closing the door, pulling back the curtain, trying to help a patient solve their individual issues. And of course, what gets all the press in the emergency department day in and day out is, the gunshot wounds and the multiple traumas and the overdoses and all that kind of stuff. But what is the bread and butter? Excuse me. What is the bread and butter of emergency physicians is the metabolic disease that we see. And that's how I started getting interested in this aspect of medicine. And by metabolic disease, really it drills down to obesity and high blood sugar. And of course, as you guys know, most obesity is caused by high blood sugar. So after recognizing really what I was doing every day, all day long, is seeing congestive heart failure and heart attacks and strokes and diabetic emergencies and diabetic renal failure and peripheral vascular disease, I decided that toward the tail end of my career here, I wanted to be proactive and not just reactive in terms of dealing with all those things. So not just managing the patient in their acute crisis, but helping them prevent that crisis. And the vast majority of these diseases are preventable. It's just that people don't a lot of times have the knowledge base to prevent them. And the medical system has not been kind in terms of educating people because of some of the incentives there that we can, talk about. But that's what made me kind of turn my direction to this area. And then, as you guys know, we've talked, I still can't quite give up emergency medicine. I'm still doing a day a week in the emergency department at the Veterans Affairs hospitals here in Dayton, because I still enjoy, again, closing the door or, pulling back the curtain and sitting down. And it's a great setting for me to work in because In the community hospitals these days, you're balancing 15 people at a time, and it's can be very stressful. At the VA, I have time actually to roll up my sleeves and just sit down and talk to the vets and spend a little bit more time with them, and help problem solve with them. So that's where I am right now.
Yeah, I love that answer because I think it hints at an aspect of your personality that's well suited for where we are in the metabolic health community, and movement, which is essentially there's a lot of areas for definition, a lot of development going on in the space, and your background as in defining emergency medicine as a discipline, I think predisposes you to contribute a lot in the metabolic health movement. So loved hearing that. And I heard you mention, many of the patients that you encounter in emergency medicine are really suffering from metabolic disease at a fundamental level. And that knowledge is not necessarily well propagated through all institutions. So would love to hear about maybe your intellectual journey and understanding that root cause and how you came to recognize metabolic disease as something preventable that you could address with your experience.
Yeah, once you kind of pull back the curtain and understand, how this all developed over the course of the last 30 years. And what I mean by how this all developed, I'm talking about the epidemics of obesity and diabetes and associated vascular disease. And we'll probably get into the physiology here a little bit. But just so people understand, if your blood sugar is high, vascular inflammation is going on. And that's really the foundation of what we're talking about here. So what is happening is blood glucose is attaching to the lining of your arteries. And I believe that issue, high blood glucose issue, is more important than high cholesterol in terms of the vascular problems people experience. But that's kind of the basis of what's going on. And we'll kind of revisit that here in a little bit, but that's what leads to those problems: congestive heart failure, heart attacks, strokes, peripheral vascular disease. So blood glucose is inflammatory, just like you hear about a hemoglobin A1C level. For people that don't know it, hemoglobin A1C is just a percentage of blood glucose that is attached to your hemoglobin cells. It's a pretty common test done for people really to screen for diabetes and pre-diabetes. So I hope most of your listeners have heard that term. But just like that blood glucose attaches to your hemoglobin, it's also attaching to other parts of your body. It's attaching to the lining of the blood vessels, causing inflammation, setting the stage for plaque buildup. It's attached to cartilage, causing inflammation, setting the stage for joint disease, for knee pain and back pain. And I find it amazing in my patients when we can lower their blood sugar a bit, how some of those aches and maladies go away. So that's kind of the whole background of this issue of vascular inflammation and how we got there. And now we can drop back, if I can, and just talk about how we got here. And I'm going to go into a little bit of the detailed history, which is the promulgation of the food pyramid by the United States Department of Agriculture in the early 70s. You guys don't remember that, but I do remember that. And actually, my dad had heart disease, and on a dime, we turned from, you can't eat that much meat, you can't eat butter, you have to use vegetable oil instead. And so we were directed in that manner. And you have to stay away from fats, and red meat was bad, based on the food pyramid. And what happened almost immediately after that is we turned from increasing the amount of carbs in our diet from 25% to 50%. And almost immediately, the epidemic of diabetes took off. The epidemic of obesity took off in the late 70s, early 80s. And then, as expected, once you become obese, you become insulin resistant. So the epidemic of diabetes took off 10 years after that. For those of you that are interested, the history of that is that, it really drills down to just basic bad policy, in that Dwight Eisenhower had heart disease. And there were a few studies done by a guy named Ansel Keys. The K is the K that you hear about in K rations. Many of your listeners may have already heard this story. But basically, Ansel Keys, who was also a industrialist, a food processing industrialist, was also a nutritional scientist. And he decided that based on, I think, bad science, a bad paper that was published called the 7 years study, 7 country study, excuse me, went ahead and, fat is the reason for Dwight Eisenhower's cardiac disease, worked with the USDA, the food pyramid got published. We turned as a country from what is a normal diet, it should be the normal state of your physiology, with basically a lower carb intake and some ketosis going on, as we have lived for, our ancestors lived for many, many years. We turned to, something new in the diet of the history of man, which was increased carbs. And that led to increases in blood sugar, and led to, again, the epidemics that we see. So that's kind of the whole background of what happened in that era, and really why we are where we are today.
Yeah, that's fascinating, because I feel like there's a ton of institutional inertia that the metabolic health space is combating against currently, and yet we had all that history of non-problems up until that point, and seemingly the recommendations changed on a dime overnight. What was that like from a practitioner's perspective? Like, did you see some pushback in the community? Was it few and far between? I'm just curious to know, like, how that was accepted to change things that radically almost overnight.
Yeah, we just kind of, as a country, kind of bought that whole scenario hook, line, and sinker. And as always, there are financial incentives behind the direction that we headed, and that, I think, is most evident in the food processing and pharmaceutical industry. And I'm not bad mouthing capitalism here. I mean, I understand their business model. I'm a capitalist. I believe people should be able to create business models and pursue them and make money. It'd be best if that meshed with what was best for society as well, which was not the case here. But basically, food processing industry in particular, you have a higher profit margin in foods that are primarily carb based and seed oil based, and that's what processed food is really. It's refined grains, sugar, and seed oils, which are pro-inflammatory and bad for you. And 70% of the food we eat in this country now is processed. So the incentives were there from a food industry standpoint to go ahead and pursue that. And then the incentives were also there to make the villain cholesterol, from the pharmaceutical industry standpoint, because, we have a pill for that. It's called a statin, Lipitor and Crestor and whatever. And so those have become the most prescribed medications in the history of the world. So lots of incentives there. We'll get into this maybe down the road. But these days, I wouldn't start anybody on a statin without doing their lipid subfractions. So if you have a high cholesterol, there are two types of LDL bad cholesterol. There's the large fluffy kind, which is not damaging, and there is the small ping pong ball kind, which is damaging. And you can have a cholesterol of 250, 300, and if you've got the favorable subfractions, it's not an issue, and you do not need to be on a statin. But the medical community bought in to the pharmaceutical model of, if your cholesterol is high, then you need to go ahead and be on a statin. So you had all these forces moving in that direction. And then the one I experienced and could observe most closely is what was going on with practitioners in their offices. And the scenario I'm going to give you is that, when I started practicing in the 80s and early 90s, docs were still hanging out their own shingle, family practice docs in, small towns. I have help staff some rural emergency departments. Um, and they work for themselves, basically small businessmen, working for themselves, having a relationship with their customers or their patients or their clients, whatever we call it, stakeholder, whatever we call them these days. And the approach was a little bit different, that they seem to have a little bit more time to sit down and talk with their patients. And again, I'm not condemning the business model that exists today, but most primary care practitioners, who are the backbone of American medicine, and we'll maybe talk about that a little bit in their role. But right now, they are given a schedule, and you have 20 minutes. You got 20 minutes once or twice a year. And so they've been kind of relegated to disease management. They don't have time really to talk about the things that we're talking about here, and diet and activity and how you can manage your medical issues or potential medical issues, or avoid medical issues, or reverse disease with lifestyle approaches, because they've only got 20 minutes. And what can you do in 20 minutes? It's like, oh, your blood sugar's a little bit high. Let's look at adjusting your medicine for that. Oh, your blood pressure's up again. Let's go ahead and adjust that. And I got a lot of friends that are primary care docs, and they don't like that model. I mean, that they would rather take a more holistic approach. But they're working for primarily health systems, or sometimes, publicly traded companies or private equity groups or whatever. So they don't have the time. So now I'm fortunate in that they're referring. I have patients that come to me referred from their primary docs in the area that don't have time to address those things. But again, it was the confluence of these things: the food processing industry, the pharmaceutical industry, and how medical care is delivered at a basic level, primary care. The incentives, if you want to broaden this, the incentives, and I'm not going to be this nefarious related to the healthcare or suggest this, but if you want to broaden it, it's like, you don't get a lot of reimbursement for insurance companies for preventing disease or reversing disease. But, if you replace a hip or do a bypass or an angioplasty, that is, very, financially favorable. And so the health systems have naturally gravitated to that model, because that's what keeps the doors open for both your for-profit and your nonprofit hospitals in this country.
Yeah, just thinking about the centralization, some of our listeners maybe aren't aware of that type of business structure in medicine in which they're engaging. And I can imagine a lot of alarm potentially from people learning this for the first time. Something that we talked about with Dr. Ovadia, which I think is a helpful or hopeful caveat to that, is, again, in the metabolic health movement, it's very decentralized. It's a lot of individual practitioners of medicine, dietitians, who cannot be. It's very difficult to move 1,000 ships compared to one ship, which is what you think of with that centralization. And the metabolic health space, I see, is simulating, perhaps on a digital level, that small town medical practitioner vibe that you were mentioning, that was much more common in the 70s. So while the current system can be improved significantly from where we are today, I see a lot of hope in how people in the metabolic health space are engaging with each other and learning, and just the passion that drives them to develop these topics and continue to help people and reverse the disease that they have.
Yeah, I couldn't agree more. As I think you and I talked previously, 2 weeks ago I was down at the Low Carb USA conference in Boca, which is just a diverse group of people that are just interested in low carb and keto and whether they should be on a statin, and health coaches, and then medical practitioners and researchers, brilliant people like Ben Bickman there. And there's just a vibe there, a lot of passionate people. And we understand that this is a movement. We're swimming upstream, because, the things are not going to change easily related to these different industries we've talked about. But there's definitely a group of passionate people with a movement. And quite honestly, how can you not be passionate when you see changes into individual people's lives. And that's why, I'm doing this now. I mean, when you have a 19-year-old whose parents are diabetic and he is heading one direction because he's 60 pounds overweight, and you put, as we'll get into, a continuous glucose monitor on him, and he sees the data on his smartphone for the first time of what's going on with his physiology and why his parents are diabetic because of the diet that they have in the house. And he changes on a dime and loses 70 pounds and reverses his insulin resistance, is going to go down a completely different road in terms of his health. You can't help but be passionate about it. And it's not just me that experiences that. It's the other docs that are part of the metabolic health movement, some of which you have had on your show, and the Dr. Kolodziks and the Brian Lenskys of the world. And there's, we're popping up out there, and we're making an impact on people's lives.
Yeah, I know Mike wanted to ask some questions about CGM, so I'll turn it over to him. But before I do, I just hearing you talk about that, I think a lot of people sort of drop into the movement because maybe they've lost someone that they care about to metabolic disease, and they have essentially like a hole in their heart or a gap in their heart where that love once was. But I think what restores that love and really brings people hope is seeing that reversal in other patients. So it's beautiful just to see like that there is hope, definitely, even if you're suffering from these conditions currently. It's not irreversible. There are things that you can do.
Yeah, and I'm going to add there that it is a combination of hope and a perspective on what can be. And I will tell you, for some of my patients, it's fear. It's that they see their parents, and that have been eating a processed food, high carb diet, for 40 or 50 years, and they see the peripheral vascular disease and the fact that maybe they have to go to dialysis 3 times a week. And they don't want that. They want a better future. And when they start educating themselves about these topics, then they realize that that it doesn't have to be that way. And so there are a lot of motivating factors there. And I welcome them all, because whether you're coming at it from a perspective of hope or a little bit of fear can be, I think a little bit of fear, if it's motivating, is not necessarily a bad thing. So.
Awesome. Well, Dr. Paul, thanks for, providing kind of the background that you provided so far around just some of your general philosophies about medicine. I think it would be nice to transition now into talking about, you've got the emergency medicine practice, which we talked about, but you also have the metabolic health practice. What does that look like from a patient's perspective? If they want to work with you, what does that journey look like from start to finish? And how do you interface with them?
Yeah, so let's talk about that. I think we first got to talk about the basic physiology of the reason people have a majority of these medical problems. So I would like to talk a little bit about insulin resistance and metabolic syndrome. Since you gave me a little crack in the door there to talk about my practice, I'm going to go ahead and put a plug in for that. I'm licensed in Ohio, Indiana, Florida, and Arizona. We see patients primarily by telemedicine, anywhere in those states. And so eventually, if people want to look me up, then we can go ahead and do an initial evaluation of them and then talk about our long-term services. But let's talk a little bit about the physiology to start, and then we can talk about what we do with the evaluation process. And my understanding is if we take a little bit of too much time here, we're going to be doing another session, or you guys are going to be linking our next session to this. So hopefully we'll have enough time to cover everything. But I do like to go over the physiology with people. I do this in my office with every patient so they understand. When I bring people in, the first thing we do is really just a discussion of, why are you where you are? So my patient population is a selected population, generally of people that are overweight. Can be people in their 20s or even a little younger, as I mentioned. a lot of people in their 30s and 40s, and even older people in their 50s and 60s. But they're all kind of getting to where they are, which is, looking primarily for weight loss. I'm going to mention I have a lot of people come in looking for weight loss, and they realize that the metabolic health problems they got after we've been able to talk for a while it's a bigger issue than just weight loss. It's really what's going on in your body related to this vascular inflammation, and what risks do you have long term. So we're talking about patients either with metabolic syndrome or at risk for metabolic syndrome. And metabolic syndrome is the affliction of the majority of overweight adults. It's the result of insulin resistance, which we'll get into. And it is consisting of primarily being overweight, having a big abdominal girth, hypertension, high cholesterol, and a lot of times either diabetes or prediabetes, or at least insulin resistance if you aren't yet pre-diabetic, because you can have insulin resistance brewing well before you become pre-diabetic. And harking back to the discussion we had about the medical system, a lot of people go into their doctors and they say, oh, your blood sugar is a little bit high. The doc says, your blood sugar is a little bit high this year. Let's keep an eye on that. That's a critical time. The medical system, because that doc only has that 20-minute period of time, it's not set up really to deal with that. So the docs, because they're so pressured from a time standpoint, getting behind in their schedule almost every day, they say, let's keep an eye on that. We'll check it again in 6 months. If your blood sugar is a little bit high, lights and sirens should be going off, because that means you're heading down that road to prediabetes. And now is the time to address it, because prediabetes is 100% reversible. And diabetes, once you cross that line, generally is not. Now, I've had a lot of patients that are diabetic. We've lowered their medications. We've even helped them get off medications, get off insulin. That can be done with a focused low-carb program. But the time to address it really is when you're pre-diabetic, or really when you just have insulin resistance. So what is insulin resistance? So this is the simple way I explain it to my patient. When you eat a carb, instantly that carbohydrate becomes blood glucose in your system. And people don't realize that. They think, pasta, that can't be bad for you if you don't eat too much of it. A baked potato, a sweet potato, a little bit of bread, but all that becomes blood glucose immediately in your system. If you eat sugar, it becomes blood glucose. But people don't realize, and this is the fault of the medical establishment, because we haven't done a good job of teaching people this, because the incentives are all in the opposite direction, as we talked. Your blood glucose rises. So what happens with that blood glucose? Well, insulin gets released from your pancreas, and that blood glucose gets driven into your organs. And the example I like to use for organs is muscles, because your muscles need energy. To contract your muscles, you need energy. That's what that blood glucose does. And in fact, blood glucose is the preferred energy source for your organs. And so limited amount of blood glucose is good. But what if your blood glucose is elevated all the time? And that's what happens with a high carb diet. Your blood glucose is elevated all the time. So after a while, that insulin's getting released. It's the key that's in the lock to open the door for that blood glucose to go into your organs. So after a while, those organs say, there's been plenty of blood glucose in the blood. We've actually taken so much in. We got extra blood glucose stored in our organs, stored in our muscle tissue, so that we don't need any more. Well, something has to happen with that extra blood glucose because of the carbs you've eaten, because blood glucose is poison to the system. Just like we talked about, it causes inflammation. So something has to happen to it. Well, it goes to the liver and gets converted to fat. So there's a process in the liver where the blood glucose literally gets converted to triglycerides, to fat, and then eventually gets deposited around the midsections of the body. So that's the reason for the majority of middle-aged Americans, some older Americans, being overweight. It's because they've eaten too many carbs. So eating fat doesn't cause this. Fat, as we'll get into, is satiating. When you eat fat, you have a tendency to not eat a lot of it or overdo it. But you can eat bag after bag of pretzels and chips and just continue to take in carbs. And so that extra blood glucose is going to become fat in your system. So the model that I talk to my patients about is we need to reverse that process. And how do you reverse that process? You lower your carb intake. So after a while, because there's less blood glucose around, those organs, your muscles, are looking for a source of energy. They're saying, hey, where's the blood glucose? We want more blood glucose. But you've lowered your blood glucose in your system to decrease your inflammation, to decrease your fatty deposition. And that blood glucose drops. And so the organs say, but we still need energy. So then they look down around that midsection and they see that fat. And they say, oh, there's our source of energy, which actually is a very natural state. To be breaking down fatty acids is a source of energy. If you aggressively lower your carb intake, that's what a keto diet is, because as that fat gets broken down, it produces ketones, which provide an energy source. That's where the word keto comes from. But at any rate, your fat gets broken down and it serves as an energy source. And when your fat gets broken down, then you start losing weight. Low carb diets are sustainable in that regard. As I tell all my patients, you can always eat something. You can always eat, some piece of meat, some beef jerky, some cheese. If you're hungry, you can always eat something. You may have to limit your carbs, but you can go ahead and eat something. And that's not the case with the calories in, calories out model. The other model is basically that you're going to take in less energy than you put out. I don't believe that's sustainable for a lifetime. The saying is you can't outrun your fork. I think cardiovascular training should be de-emphasized in comparison to strength training. So this is what patients get from me. Get off the treadmill, get in the weight room, and I don't really care about how much fat you eat. That's not completely true. We talk about good fats and bad fats, but it's completely different than the mainstream model. And, fortunately, people have success. But that's the insulin resistance model that I wanted to go over. Basically, those organs are saying to the insulin, stop. We aren't going to listen to you anymore, insulin. And when that happens, then that's when the fats start getting broken. Then that's when I misspoke. When insulin resistance happens, that's when the blood glucose continues to rise. And you need to reverse that by tapping fatty acids as a source of energy. By the way, people hear of fatty liver disease. Fatty liver disease is basically that deposition of fat happening. And so fatty liver disease is not caused by eating fats. It's caused by eating too many carbs. So we want to reverse that process basically and have you burn fatty acids. Same model as the bear in winter. It's out in the fall. It's fattening up with berries and roots. It's laying down all this fat. And then it goes and hibernates and it lives off fat. It's in ketosis for 5 months. We in America, most of us have food at our fingertips 24/7. So we don't have that issue where we go for long fasts for a period of time. So we have to control our carb intake to kind of achieve the same end. The bear comes out in the springtime, it's skinny at that point. So what we want to do is help our patients lose that fat at the same time, retaining significant muscle mass, which I'm sure we'll talk about as well. So longest explanation, Mike. I hope that's okay in terms of giving that background, and then we can get into exactly what we do with the program and CGMs as well.
Yeah, absolutely. And I'm glad you brought this up because I think there's so many different interesting things we can talk about. You mentioned lights and sirens in the context of, somebody going to a doctor's visit and, let's say they've got slightly elevated blood sugar and the doctor just says, oh, we should take a look at this. We should, monitor it. What are some of those warning signs that doctors really should be spending more time with their patients on? You mentioned blood glucose. What would be like the level of blood glucose that you would start, alarm bells would start going off in your head on? And then maybe what are some other things you might look at to start saying, okay, we've got to start addressing this?
Yeah. So related, the classic tests related to blood sugars are a fasting blood sugar at over 100. The generally accepted definition of prediabetes is if you have a fasting blood sugar over 100. Fasting means you haven't eaten for 10 or 12 hours. You go get your blood sugar done in the morning and it's over 100. The cutoff for diabetes is 125. The other variable that is used is what we talked about previously, the hemoglobin A1C. So hemoglobin A1C is literally the percentage of glucose molecules that are attached to your hemoglobin molecules. So if your hemoglobin A1C is 5.2, then that means 5.2% of your hemoglobin molecules have glucose attached to them. And of course, that relates just to the amount of blood glucose that's in your system. The cutoff for prediabetes with a hemoglobin A1C is 5.7. And then for diabetes, it's about 6.5. Unfortunately, insulin resistance can start years before you even have a prediabetes blood sugar or hemoglobin A1C. So I think the most important test, which I do in all my patients, the most important test to assess where you're going in terms of potential blood sugar issues is a fasting insulin level. Because the fasting insulin level tells you exactly where your risk is. So the physiology is this: if this insulin resistance thing is starting to go on, then what's happening is your insulin level is risen. And if your insulin level's up for the reason we talked about, that should be forcing blood glucose into your organs. Again, remember, it's the key in the lock. And if that fasting insulin level is up and the blood sugar is still up a little bit, then that means there's a problem. That means those organs are resisting that signal from insulin and not taking in as much blood glucose, just as we talked. So that indicates that those organs are resisting the signal from insulin. Now, you can get an exact assessment of your level of insulin resistance by doing a fasting insulin level, which in and of itself is very helpful. But if you do that in conjunction with a fasting blood glucose level, you can see that relationship between the two. You can actually plug those two numbers into a formula called a HOMA-IR. Don't want to get too wonky, but that's homeostatic model of insulin resistance. And it gives you an exact absolute number as to what is your level of insulin resistance. And you can have insulin resistance, again, going well before you have a high fasting blood sugar level or a high hemoglobin A1C. So if you're overweight or you have prediabetes or diabetes in your family, even if your blood sugar levels are not reaching that level, then that's a good assessment. The clinical characteristics that have always been used to determine if your blood sugar is high is thirst, because when your blood sugar is high, you're trying to pee out extra blood sugar as well. So you drink a lot, you urinate a lot. And then there are other subtle signs like numbness in the hands and the feet, for example, or just truncal mid-area weight gain. But unfortunately, once that's happening, you're down the road pretty far. I believe a fasting insulin level and a HOMA-IR calculation, which I talk about in the book, is critical. I think these are more important tests for most people than cholesterol. The one thing I would suggest to people when they go to their doctor is, if you get a cholesterol level and it's a little bit high, get those subfractions done so you know exactly where you stand related to that. And then ask for a fasting insulin level and a simultaneous fasting blood glucose. And unfortunately, that's a rare test. Sometimes OB-GYNs do it because it's a marker of a problem in women called polycystic ovary disease. But other than that, I don't see it done routinely. I think it will become more popular because of the valuable information it provides. But I would push your listeners to ask their doctor for a fasting insulin level, because it provides a wealth of information.
Yeah, and I'm glad you brought that up, because in many patients, it's possible to have normal blood sugar but excessively high insulin,
Yeah.
right? Which means that you're starting to have that insulin resistance problem. Curious, is it possible to be obese and not be insulin resistant? Like, have you ever seen that? Or
Yes. Yeah. Yeah. It happens. It's rare. Okay. There are people that just don't develop insulin resistance. I would say it's a minority, maybe 5 to 10% of the patients. Again, I attract a patient population that's mostly overweight, but occasionally I'll have people come in and they don't have insulin resistance. And quite honestly, it makes it a little bit harder for them to lose weight. You don't have an enemy that you can attack in that regard. Not an identifiable energy. They still do enemy. They still do well on low carb diets, intermittent fasting, as we'll get into, strength training. But yeah, there are a minority of people that are overweight that don't have insulin resistance. Just like there are a minority of people that are skinny that do have insulin resistance, and there are certain ethnic groups that's the case for. South Asian people, for example, have a tendency to be, the term that's used is skinny diabetics.
yeah.
People that are of, for example, Indian descent need to be careful related to that.
And do you think like that small subset of the population, I think you said 5 to 10%, do you think that's typically like genetic, or they've got something else going on where they can be obese without having insulin resistance?
Yeah, I think it's
like a very interesting thing.
Yeah, it's very interesting. I think it's mostly genetic.
Yeah.
And maybe that's the reason it's a little bit harder to combat. But again, for people that want to, address that, low carb diet, intermittent fasting, and strength training is the way to go. I feel that, you've now heard me mention strength training a couple times, and I'm sure we'll get into this in more detail. But the reason strength training is effective is because for people with insulin resistance, when you increase the size of your muscles, you're increasing the quality and the receptivity of the insulin receptors on those muscles. So they're soaking up more insulin. So that's another mechanism to help reverse insulin resistance. So, I have people do basic cardiovascular training, follow the American Heart Association guidelines for their cardiovascular workouts. But the focus here is strength training. I don't know if I mentioned to you guys, I did a TikTok, which was get off the gosh darn expletive cardio machines. And I didn't mean completely ignore your cardiovascular training, but if you follow the AHA guidelines and you cardiovascular train at a rigorous rate, you can get all your cardiovascular training that's recommended in 75 minutes a week. So, you can spend the other 3 hours working on your strength training, building that muscle mass, which is important not only for insulin resistance, but also important as we age, when we're all losing 7% of our muscle mass over age 30. So you guys got to start watching out here now too. Okay. And then the last one is that you can fight osteoporosis as you get older by having an increased muscle mass, because there's a little bit of truth to the saying, if it doesn't kill you, it'll make you stronger. Your muscles, when they're bigger, will put more stress on your skeletal structure. When your skeletal structure is stressed, you get increased deposition of calcium, so you can fight osteoporosis with strength training as well.
Yeah, I think what you're referring to is strength training increases not just muscle mass, but also bone mass, right?
Mm-hmm, mm-hmm. Absolutely.
Awesome. Well, I think, you did a good job of kind of setting the stage for kind of what you specialize in with your practice. You mentioned what I assume is kind of your typical patient, somebody who's struggling with insulin resistance. Talk to me about the kinds of patients that you see and how they find you, what the patient journey looks like, kind of from start to finish.
So how they find me is they recognize that just what we talked about, what they've been doing hasn't worked. They've been told that they just need to take in less energy than they put out. So they're on the treadmill machines and they're starving themselves. And they realize it hasn't worked and it hasn't been sustainable. A lot of people either don't have success with that, or they yo-yo. They lose some weight and then they go back up. And so they realize, you know, it is kind of a little bit common sense. What we've done for 50 years hasn't worked. There's got to be a better way. So just kind of like you guys, they realize that there's got to be an alternative that's more effective. So they begin to find low carb or think about low carb. And that's the patient population I attract. They've tried other things. They realize it hasn't worked. You know, we've had great success, and we try and publicize that on our website and with my social media stuff. And we've had great success, you know, without the new weight loss medications. We'll eventually, I think, maybe in a different session, get into the weight loss medications, which I do use in a very sparing manner. There are risks associated with their use, so they need to be used exceptionally prudently. But they realize that there's got to be a better way. You know, a simple thing as this. Yeah, I just saw that movie last night that was made in the 30s and 40s, and nobody was obese, you know, or you pull out photos from the 40s or 50s, and obesity wasn't a thing then. And so people's wheels start turning. So they come to me for that initial assessment. A lot of people, just because they want to lose weight, and then they begin to understand insulin resistance, and the majority of them have insulin resistance. So we begin to address that. So that's generally how I attract patients. It's patients that have been on a search, been on a journey, haven't found what has worked, and now are beginning to understand that the metabolic health community, the low carb community, has something to offer.
Okay, so these folks find you. You know, they're typically disaffected by the medical system, by the nutritional guidelines. They've tried a few things in the past, yo-yo diets, calories in, calories out. It hasn't worked for them. It's been an abysmal failure. You know, then maybe they watched a TikTok video of you talking about low carb diets, talking about, you know, how to fight insulin resistance, and they sign up, I assume, on your website for a consultation. You know, kind of take me through the process from there.
Okay, thanks. So actually, that's one source. The other source is, again, fortunately, I'm getting primary care docs referring people to me. You know, initially they were kind of looking at me like, what's that guy doing over there? You know, with this low carb stuff and this insulin testing and all this stuff. And now they're referring people to me because they've lost weight. And the other big hallmark of that success is what I call deprescribing. You know, they've lost weight. They're able to come off their blood pressure medicine. We're able to lower or eliminate their need for insulin. So I track people that way as well. So people come in, and the first thing we do is sit down with them and talk about what their goals are. Then we go over their entire history to understand specifically, you know, what are their potential risks. You got to check things like thyroid issues, make sure thyroid isn't responsible for their weight gain. We talk about their current diet. We talk about their social situation, because if you're going to go low carb, you got to have some of your family at least buy in to accept what you're doing, because, you know, the eating pattern in the family is going to be accepted. The good part of that is I'll have a patient that go low carb, and a lot of time their spouse and even their kids will, once they begin to understand the value of this. But people can sign up on the website, or they can just call us. My staff is exceptionally knowledgeable, and do, you know, we'll do like a 10 or 15 minute phone consultation. They'll take the background information, they'll review it with me. And then I usually initially bring in people for what I call a 2-week trial. So basically, this is offering the people the opportunity to try before you buy. You know, I want them to understand what we're doing. There's, of course, a cost for the 2-week trial, but you don't have to make a long-term commitment. You can learn what we're about first. And then the medical approach is this. They come in, we go through that history, we order labs if they haven't had labs recently done. I almost always need to order a fasting insulin level and a simultaneous blood glucose, because very few patients come to me with that, despite the fact that they have a better knowledge base related to insulin resistance than most people. And then the other thing we do, which we'll get into here, I'm sure, is we put a CGM on them, a continuous glucose monitor. and I tell them not to change their diet. So these are not necessarily diabetics. These are people that we are using continuous glucose monitors in that maybe are just overweight, or maybe they've been told their blood glucose is a little bit high, but they have no idea what that pattern is. And I have them wear that for 2 weeks, and we follow their pattern so we can see how high their levels are and what the variability is. I think, a lot of these people come to me complaining of, and I don't want to over tout this, but a lot of people come in complaining of, I don't have any energy, and, I get brain fog in the afternoon. Well, there's a reason for that. And that is that variability that's taking place with your blood sugar. What is happening? Your blood sugar is spiking. And then, of course, the body releases insulin. A lot of times the body does respond to that insulin, and your blood glucose drops. And that's the reason that people around the world take siestas sometimes in the afternoon. It's that physiology. So if we can level those curves out over a period of time and decrease the overall level of blood glucose using a continuous glucose monitor, then that can be very effective in helping addressing that. And of course, we use it as a tool to decrease insulin resistance. But the main thing we do in the first 2 weeks is follow those blood glucose curves with a continuous glucose monitor, and then do that initial set of labs. Go ahead.
Maybe stepping back for a second here, for folks that might not be familiar, what is a continuous glucose monitor, and how does it work?
Great. Okay, so continuous glucose monitors are those devices that you see on the back of the arms of diabetics. And they have been out for about 15 years. They were devised originally to help dose insulin. So rather than a diabetic having to stick their finger, 3 times a day, you get a 24/7 reading of your blood glucose on your smartphone. So you put the device on, it puts a little sensor under the skin. The sensor under the skin, which will stay there for 2 weeks, they last for 2 weeks before you have to swap them out, will give you what your blood glucose reading is within an error rate of about 5 to 8%. But all you have to do is look at your smartphone. You basically wave your phone over the CGM, and then you get your glucose reading at the time, and you will get a graph of what your blood glucose looks like over the course of the last 8 hours. So that sensor equilibrates with the blood glucose in the area, and then you pick it up. So once you eat something, within 5 to 10 minutes, you can see how your body responds to that. So as I mentioned before, patients, sometimes have an aha moment with these because they had no understanding what was going on with their blood glucose or insulin physiology. And now they can see the graph on their phone in real time. There is a test that is done in pregnant women sometimes called an oral glucose tolerance test. And it's when the women are asked to drink a sugary drink, and then their blood sugars are measured in the office, generally by drawing blood, over the course of the next 3 or 4 hours. Well, with the CGM, you get a blood glucose every day. You get an oral glucose tolerance test every day. You can see exactly what every food is doing to your blood glucose. The other thing you get every day is a fasting blood glucose. Every morning, you get to see what your fasting blood glucose is. So we use this device diagnostically. Again, I tell people not to change their diet in the first couple weeks, and then we put that data together with their insulin data to put this plan together of low carb, intermittent fasting, and strength training. And the reason seeing those CGM curves is sometimes an aha moment is because the way my patients have put it, you can't unsee that data. You can't eat a donut, or a Snickers bar and unsee that. And I know it sounds a little bit trite, but for some people, their lives are changed by that. Their doc may have been talking to them for a period of time in their office originally of your blood sugar is a little bit high, and they don't really understand that whole physiology that we went through and what it means. But when they see data and when they see curves and when they realize that, I don't feel good in the afternoon because maybe of a high carb lunch, or for me, as was the case, I don't feel good the next morning when I've had a lot of carbs before I go to bed, they begin to understand when they see that blood sugar spike to 160, 180, and then drop abruptly. And I have patients that come in that don't know they're pre-diabetic, and a CGM helps us define that, because another criteria for prediabetes is spiking blood sugar over about 160. So if you're spiking your sugars that high, you got insulin resistance going on, and you're in the pre-diabetic range, in addition to the fasting blood glucose and the hemoglobin A1C parameters, which can miss it occasionally. And I even have people come in and they're diabetic. They're spiking to 220, 230, and they don't even know it. So they come to me because they want to lose 20 pounds, but then they realize how big an issue this is and what it's going to mean to their future health. So that's how we use CGMs. And in that first phase, we use them diagnostically, and then later on, we'll use them therapeutically to guide their low carb diets.
Yeah, that's fantastic. And just so people understand, just piecing together some of the things you said previously, is it you look at the results from the CGM monitor and you see, okay, here's a spike. Do you sit down with the patient and explain to them, you see that spike right there? Like, that caused vascular inflammation. And then also, like, do you also have kind of the flip side of it? Because when a lot of people eat lots of sugar, you also get the crash, and that could be explaining their low energy level, right?
Absolutely. But you can get the crash with not only with sugar, but with any kind of complex carb, potato, rice, etc. Yeah, absolutely. That is the value of following these numbers, because then they can use that to go ahead and modify their diet going forward. So, it's a teachable moment, and it can be life-changing. In the book, which we'll get into, another shameless plug, the continuous glucose monitor revolution for non-diabetics, that's available on Amazon. I talk about this, and the last chapter in the book is CGMs change lives. And it's not every patient it changes their life, but it's a lot of patients, because the way my patients put it is, once you've seen that data, you can't unsee it. You know what's going on now, and you just naturally gravitate to a lower carb lifestyle. And that's why another reason I think a low carb approach is sustainable, because you understand what's going on, and you really want to feel better. And I get patients that get to the point where they don't think about that candy anymore. Quite honestly, they realize pasta is going to be a very occasional thing. And that's the way they want it. They don't mind it. They've embraced that lifestyle because they have an underlying foundational knowledge base of, what was happening to their system before.
Yeah. And so, you've talked about how you use CGMs to kind of guide the diet. Talk to me a little bit about, like, what is the diet that you prescribe to your patients? Obviously, low carb, there can be lots of different iterations of that, whether it's keto or carnivore or ketovore, right? There's a bunch of different options there. How do you kind of go about deciding what is the best diet for your patient?
So this is my philosophy, is that diets in and of themselves are restrictive. And I don't want to place too many additional restrictions on people. I find that my patients really kind of find their own way. If they want to go just low carb, if they want to go keto, if they want to go carnivore. So we talk more about what is your carb limit. What do you got to target for your carbs? I ask everybody to count their macros. Macronutrients are carbs, including complex carbs and sugar, fat, and protein. Everybody has to count their macros, because they got to know exactly how many grams of carbs they're getting in a day. And also protein is very important, as we'll talk about. When you're strength training, you got to be having protein as well. So I usually target a level that I think is doable for the patient. So I have patients that come into me and they've already been on low carb or dabbled in low carb, and we might say, well, we're going to make your limit 50 grams a day. You got to get familiar with what these numbers mean. And that doesn't mean that you can't got to do 50 every day. It means that, if you go out once every couple of weeks for a special dinner, that's fine. But you got to have a general idea of what your goals are. So my general goal for patient is about 50 grams a day. I feel that it's a lot easier to go to 50 grams right off the bat, even for somebody that's been consuming 300 grams. I just find it's very painful to go, oh, we're going to go 150 and then we're going to go 100. And they aren't making any progress in terms of weight loss or feeling better that time. So usually we go to 50, maybe 75 grams a day. And then a lot of my patients will decide to dial it lower than that, 35-ish grams a day. And then some will decide to go carnivore or keto, which I support if that's what they want to do. Another variable, remember, Mike and Ryan, down the road we can get into is measuring ketones. And I got a great relationship with people at Keto Mojo that sell finger stick keto devices. Eventually, I think there's going to be devices, continuous ketone monitor devices that are going to be coming out. But measuring ketones is another variable, which eventually let's talk about. So what we want to do is set a carb limit that is doable, but then I kind of let people do what they want. I have a health coach that works with me, and they will cater to, maybe I want to go carnivore, or maybe I do want to go keto, or maybe I'm just going to stay in the 50 gram range. And we provide people all kinds of information, but I don't dictate a meal plan to them in terms of, what you can eat in the morning and what you can eat in the evening. So we kind of focus on carbs, and then we focus on protein, because getting adequate protein is important too. And usually it starts at about 100 grams a day if people don't have kidney problems. You need to get 100 grams of protein in a day for the strength training component, et cetera. So, we can maybe talk about that in more detail in the next session. But again, what distinguishes me a little bit from, other docs is I usually say, notice I said carbs and protein. I don't worry about fat that much. Fat is satiating. I want people eating more fat. We do get into the good fat and bad fat discussion because we've been led down the road of eating bad fats, which are primarily seed oils and fried fast food. So we do talk about good fats and bad fats, good saturated fats, olive oils, avocado oils, etc. But basically, I tell people, let's focus on your carbs and let's focus on your protein. Don't worry about fat that much for right now, other than that foundational understanding of good fats and bad fats. And then again, the other thing that distinguishes me a little bit is I tell them, let's minimize the cardiovascular training and let's get you strength training. And I don't want to scare people when I talk about strength training. That might start with a 5 or 10 pound weight at home and a set of bands that cost $25. Okay. It's not like, people that are intimidated by the gym setting don't have to start going to, their local LA Fitness or a Sporta or whatever and be pumping iron with the big boys. We aren't talking about that. We're just talking about getting a start on strength training, making it part of your lifestyle changes, so then you can progress over time.
And do you build out like a strength training program, like particular for that person, or like, and do you have strength trainers that work on your team?
Yeah, I have a great health coach, certified personal trainer, and he gets all this. I have a lot of middle-aged, especially women. First of all, I'll say that women seem to understand the importance of metabolic health more than guys. Guys would just, us guys would rather just stick our head in the sand and wait till we're, in crisis in the emergency department. But the women have a tendency to get it a little bit earlier. So he is great. He works with patients that have never lifted a weight in their life, and they begin to understand the importance of this. And, one anecdote, that I like to mention is I had a woman like that, never lifted a weight in her life, was 3 or 4 months into it, told me that she was brushing her hair in the mirror one day and recognized for the first time in her life she had a bicep. So she was absolutely thrilled, and she went on and changed her body composition tremendously with the combination of low carb, intermittent fasting, and strength training.
Awesome. Well, I know there's tons of more topics and we could probably go on for hours, but I know you've got a place to run to. So maybe I'll just pass it back over to Ryan to wrap us up, and then maybe give you a chance to plug anything else you like to plug.
Okay, thank you.
Yeah, thank you so much for the wonderful conversation, all the different topics that we were able to cover, from the actual science behind what's going on with your body with respect to insulin and blood sugar, and the difference that optimizing those variables can make. At metabolichealth.com, we take a holistic approach to how lives can be transformed, which includes diet and exercise. So very happy to hear you touch on those topics. And just as an outro, would love to hear what's the website where people can reach you at, and any socials that you want to plug in particular. We'll be including a link to your book in the comments or description of this video as well.
Okay, thanks a lot. First of all, I want to thank you guys for having me on, and I wanted to talk just briefly about all the great information that's on your website. We got together, and I had a chance to go over your website thoroughly. There's a wealth of information out there for people on this topic, so please have a look at metabolichealth.com and begin to understand what we've been talking about here in terms of the evolution of what's going on with American diet and really how you personally can fix it. Thanks for allowing me to plug the book. It's on Amazon. It is The Continuous Glucose Monitor Revolution, again, for non-diabetics. It's the most popular book on Amazon about CGMs. This is becoming a movement of people wearing CGMs to understand their physiology as well. And again, my practice is metabolicmds.com. It's the word metabolic, then mds.com. I have some other providers working with me. You can go on there. If you're interested in the practice, there's a form you can fill out and have one of our staff give you a call. Again, I'm licensed in Ohio, Indiana, Florida, and Arizona. And then social media wise, I'm on TikTok. Usually if you search DRKOLO, you'll find me. I guess on TikTok, it's dr.kollo. And then I'm on Instagram and LinkedIn and TikTok and also Twitter. So I appreciate you guys posting the links when you publish this.
Great, of course. And thank you, viewers, also for tuning in. We'll see you next time on Reimagine Wellness.
Thank you.
Thank you, Dr. Kolo.